when working with patients, we would pick up on certain hesitations when asking patients to get into gowns or when doing more sensitive skin checks. So we understand that there is a difference in comfort level when performing skin checks.
In episode 67 of Dermatology Weekly, Dr. Vincent DeLeo welcomes Dr. Atieh Jibbe to talk about when patients have anxiety for full-body skin examinations. This is Dermatology Weekly, the official podcast of MDH Dermatology, where we bring you interviews with clinical and research leaders in the field of dermatology, as well as what's new in the field. I'm the voice of MDH Podcasts, Nick Andrews. Coming up later today in news, a link between neuropsychiatric disorders and atopic dermatitis, and should healthcare workers wear masks at home? Remember, you can contact the show by emailing us at podcasts@mdh.com. You can follow us on Twitter at mdhderm. Okay, it's time for the latest in dermatology news. We begin today with melanoma risk and biologics for certain patients. The risk for melanoma was increased among patients who were taking biologics for immune-mediated inflammatory disease compared with patients who were naive to biologics. The association did not achieve statistical significance according to the systematic review and meta-analysis which were published online in JAMA Dermatology. In the review, researchers identified 7 cohort studies from Medline, Embase, and Central databases which were published between 1995 and 2019 that evaluated melanoma risk in about 34,000 patients receiving biologics and more than 135,000 who had never been treated with biologics and who were receiving conventional therapy for psoriasis, RA, or IBD. Of those studies, 4 were in patients with RA, 2 were in patients with IBD, and 1 study was in patients with psoriasis. 6 of the studies examined patients who took TNF inhibitors, but only 1 of the 6 had information on specific TNF inhibitors. The researchers analyzed the pooled relative risk across all studies. They found that compared with patients who received conventional systemic therapy, there was a non-significant association with the risk of melanoma in patients with psoriasis, RA, and IBD. The researchers wrote that more specific cohort studies are required to improve certainty. They noted that the studies in the future would need to account for the risk factors and latency period of melanoma. You can read more about the data and the studies by clicking the link in the podcast notes. And having a diagnosis of atopic dermatitis was associated with a greater risk of developing anxiety, depression, bipolar disorder, and other major neuropsychiatric disorders in children, adolescents, and in adults. This is according to a study that was presented at the annual meeting of the Society of Investigative Dermatology, which, of course, was held virtually. Researchers conducted a cohort study of patients with AD in the UK by acquiring data from the Health Improvement Network Electronic Records database. They matched AD patients with up to 5 patients who did not have atopic dermatitis. Outcomes of interest included anxiety, depression, bipolar disorder, obsessive-compulsive disorder, ADHD, schizophrenia, and autism. Patients entered into the cohort when they were diagnosed with AD, registered by a practice, or when data from a practice was reported to THIN database. The researchers stopped following patients when they developed a neuropsychiatric outcome of interest, left a practice, died, or when the study ended. Overall, more than 434,000 children and adolescents with atopic dermatitis were matched with just under 2 million controls, and 645,000 adults were matched with just under 3 million controls. In the pediatric group, demographics were mostly balanced between children with and without AD. The average age ranged between about 5 and 6 years. In pediatric patients with AD, there was a higher rate of allergic rhinitis and asthma than in the control group. For adults, the average age was about 48 years in both groups compared with patients who did not have AD. Adults with AD also had higher rates of allergic rhinitis and asthma. The researchers adjusted for age, gender, socioeconomic status, asthma, and allergic rhinitis. They reported greater rates of bipolar disorder, OCD, anxiety, and depression among children and adolescents with AD compared with controls. In the adult cohort, AD was associated with an increased risk of autism, OCD, ADHD, anxiety, depression, and bipolar disorder. Dr. Joy Wan is a postdoc fellow in dermatology at the University of Pennsylvania in Philadelphia. In her presentation, Dr. Wan said that one reason for the increased associations among the adult cohort is because she and her colleagues looked at incident outcomes and that many children may already have had these comorbidities at the time their entry into the cohort. She noted that the study may have observation bias or unknown confounders, but she hopes these results raise awareness for the association between AD and neuropsychiatric disorders, although more research is needed to determine how AD severity affects neuropsychiatric outcomes. And finally, today, an important question for doctors, nurses, techs, and all those working in healthcare. Should you wear a mask when you're home? A recent study from China suggests that wearing a mask at home when everyone in the home feels fine may indeed reduce the risk of transmitting the virus to their families. However, the benefits of wearing a mask could outweigh the costs. Dr. Jean Noble is an emergency care doc at UC San Francisco. She said that her gut reaction to this is that home mask use for healthcare workers would place quite a bit of burden on those workers and on their families. She told MD Edge that wearing a mask for a 10-hour shift already represents a significant physical discomfort, causing sores across the nose and behind the ears. The emotional toll of physical distance that comes with mask use, with limited facial expression, is also quite real. The benefit suggestion comes from a study that was published online in late May 2020 in BMJ Global Health. To assess the predictors of household transmission of the virus, the researchers from the Beijing Center for Disease Prevention and Control conducted a retrospective study of 124 families in Beijing that had a confirmed case of COVID-19 as of February 21, 2020. They surveyed family members by telephone about household hygiene. During the 2 weeks following the onset of primary case, secondary transmission occurred in 41 families. Overall, 77 of 335 family members developed COVID-19. A multivariable logistic regression analysis found that in households in which family members wore masks at home before the first person became ill, there was less likelihood of transmission of disease to a family member compared with families in which no one wore a mask prior to the illness. The researchers reported that face masks were 79% effective in disinfection and 77% effective in preventing transmission. However, wearing a mask after symptom onset was not protective. The findings support universal mask use and also provide guidance on risk reduction for families living with someone in quarantine or isolation and families of healthcare workers who may face an ongoing risk. Still, other precautions may be more important. Dr. Mark Rupp is the chief of the Division of Infectious Diseases at Nebraska Medical Center, which is in Omaha. He said he thinks the best way, by far, for healthcare professionals to protect their families is to carefully employ appropriate infection prevention on the job. He told MD Edge that the combination of administrative interventions, engineering improvements, and PPE is very effective in preventing transmission in the workplace. And that's it for Dermatology News. Peer-to-Peer with Dr. Vincent DeLeo is coming up next. Welcome back to Dermatology Weekly. I am Nick Andrews. It's time now for Peer-to-Peer with Dr. Vincent DeLeo.
Today we're talking to Dr. Atieh Jibbe about reducing patient anxiety caused by full-body skin examinations. Dr. Jibbe is here with us from the University of Kansas Medical Center in Kansas City. Thank you so much for joining us today, Dr. Jibbe.
No problem. My pleasure.
So let's get started. Full-body skin examinations can create anxiety for some patients. What led you to create the pre-encounter survey you used in your study?
So I think that throughout my time at KU and my co-residence time, we've noticed that when working with patients, we would pick up on certain hesitations when asking patients to get into gowns or when doing more sensitive skin checks. We're also a diverse group of individuals and are familiar with differing religious practices. So we understand that there is a difference in comfort level when performing skin checks. We also noticed that our patients would sometimes request only female, only male, or they would request that they're not in a gown. So these factors led us to think about the anxiety our patients feel when they visit us in the office and how we could try to reduce that anxiety. We pondered the fact that with the frequency of full-body skin exams by dermatologists, oftentimes dermatologists can get oblivious to the nature of the exam and how sensitive it can be and how it can create anxiety for a lot of people. Oftentimes, I think that the lack of acknowledgement of that anxiety or the lack of acknowledgement of the fact that we are doing a sensitive exam can make people feel more uncomfortable. So we thought with the purpose of our survey, we would not only acknowledge our patients' anxiety and tell them, hey, we know that this is a sensitive exam. How are you feeling about this? What do you want us to look at? What do you not want us to look at? That this would help reduce anxiety. Also, it would give us knowledge on what patients are thinking. And with the post-exam survey, it would give us knowledge into, did this survey help? Are they feeling less anxious now that we've acknowledged the fact that this is a sensitive skin exam?
That's great. I think many of us, as you say, forget that this can be a problem for some patients because we do these all the time. So I think that's a great understanding of what's going on in this interaction with our patients. Can you share with our listeners the results of your studies?
Yes. So for listeners tuning in, I'll give them an idea of what our survey incorporated so they have an idea of how we got our results. So our pre-examination survey asked for age, gender, and if patients had a preference on what body parts they would like examined. And then they were asked to circle which body parts they did not want examined. After the visit, we had a post-examination survey that asked if patients were willing to complete the survey next time and if the pre-examination survey helped reduce anxiety. So we interviewed 34 patients, 14 male and 20 female, and of those, we found a female predominance in both exclusion of certain body parts examined, preference for us asking what they wanted examined, and also we found that more females found a change in their anxiety level after the post-examination survey. So overall, just to give you an idea, the most category that was excluded from exam was the genital area, and that was 7 females that requested that and 4 males that requested that. And as for the preference for asking, we had 9 of the 20 females that we interviewed preferred the survey, and 7.2 males preferred the survey before the exam. And then we had about 8.3 females who felt that there was a change in anxiety with the pre-examination survey compared to 6 males.
Very interesting. You point out about what we would expect, that people, both males and females, might not want their genital areas examined. Can you tell us about other areas that some of the participants didn't want examined that we might not think of?
Yeah, so going in order, I would say the genitals was obviously the most requested against being examined, but then the buttocks, the breast and chest, the legs, feet, abdomen, and scalp. Scalp had 0, so I guess I won't bring that in, but the buttock, breast, and chest, I think, are areas we expect not to examine. Sometimes when patients are more concerned about the sensitive nature of the exam, the legs, I feel like we see that because patients just don't want to have to take their pants off and go through that hassle, but those are what our results showed.
And what about gender differences? Any particular ones there?
Yeah, so the females we found had the most amount of exclusions with, like I said, the genital exam being the most excluded in 7 out of our 20 females. The buttock was equal between male and female, and the breast and chest area was actually equal between breast and female, but it seems that females are more open to having those areas examined than the genital area. This year, you could hypothesize that it's possibly that way because females have regular OBGYN follow-up, so they already are having those annual exams and don't need it examined at a dermatologist's office. We also found that females had the most impact in their change of their anxiety after the post-exam survey.
Well, that is a wonderful summary of your very interesting study, and I think very helpful for us to realize this sensitivity in our patients and something that we find routine. What tips do you have for residents in training to learn how to put a patient at ease with a full body skin exam?
So obviously the study shows that the pre-exam survey is one way to assist patients in reducing anxiety about full body skin exams, but other methods that don't involve the survey include identifying yourself as soon as you walk in. I feel like patients are more apt to be more comfortable if they know who you are, your name, what your role is in the healthcare profession, and what you're doing for them. Talk through what you are doing. So when you are starting to look at a patient's body and you're doing that full skin exam, talk through what you're doing, look at one body part at a time, and indicate what you're going to look at before you start looking at it. If you walk a patient through the exam as you're doing it, it makes them feel a little bit more in control of the situation rather than just unexpectedly revealing certain parts of their body without them having a foreshadowment of that. Also, a great way to start the exam is if you ask the patient what they are worried about or what they're here about and ask them to point it out, and that can guide the exam. So that immediately gives you a segue to go start an exam, and I feel that a patient would be more comfortable if they're indicating on their body what they want you to start looking at. And then you can transition to the full body skin exam from there.
Those are great tips. Now, in current times, patients aren't able to get to the office to have a routine full body skin examination done because of the COVID pandemic. How are you using telehealth to help in the meantime if patients have a concerning lesion?
We've been using telehealth in our office, and though sometimes it's difficult to tell through the video because it is dependent on the patient's high resolution video quality for us to be able to really tell what lesions are. So number one, we try to identify the lesion. If we're able to do that confidently, we try to give a diagnosis. We also encourage patients to send high resolution pictures to our electronic record called MyChart. It's a patient portal that patients can send their high resolution pictures to us prior to the visit, so then we can discuss the lesion during the visit. During the visit, if we do not have a picture, if we cannot tell what the lesion is, we get a history and decide if the history warrants an inpatient visit that is more urgent and that would require biopsy. So triage is a big portion of telehealth. Some patients won't need to come in after we triage them, and some patients, because we can't tell what the lesion is or we're concerned based on the patient's history, then we have the patient come in for an inpatient visit and potential biopsy.
Great. We want to thank you very much for joining us today. Do you have anything else you'd like to add before we wind up the podcast?
I think that we covered majority of the article. I just want to wish everyone stay safe during these times and stay positive.
Have a good one.
And that concludes episode 67 of Dermatology Weekly. Derm Weekly is produced by Elizabeth Meshkati and Melissa Sears. The peer-to-peer portion of our show is hosted by Dr. Vincent DeLeo. Our guest this week was Dr. Atieh Jibbe. The news portion of Dermatology Weekly is produced by MD Edge editor Elizabeth Meshkati. All MD Edge podcasts are produced by our editor-in-chief and the editor-in-chief of Medscape, Dr. Ivan Aransky, as well as MD Edge executive editors Kathy Skarbeck and Mary Ellen Schneider. Social media for Dermatology Weekly and MD Edge Dermatology is produced by Kyla Clark. Dermatology Weekly is engineered, edited, and produced by Tyler Mundek. For all of us here at MD Edge, I'm Nick Andrews. You're listening to Dermatology Weekly.